Okay, welcome everybody to this Greater Manchester Cancer webinar. I'm Matt Everson. I'm one of the Associate Medical Directors at the Cancer Alliance. And so today's webinar is focusing on multimodality treatments in lung cancer, a really rapidly changing treatment paradigm that brings with it many new complexes, new pathways, particularly neoadjuvant treatment. That's going to be a big focus of today's discussions. So the webinar today has a number of different purposes. It's an opportunity for us all to try and keep up to date with this field of lung cancer care. So there's a strong educational component and an update on evidence bases. We're going to reflect a little bit on our own specific Greater Manchester pathways and processes. So we've got quite a focus on the standardized processes that I think are really pivotal to try and ensure a successful delivery of this quite complex pathway. And everyone has a role to play in that. And also just discuss the service delivery model specific for GM. So whilst there's lots of complexities, whilst it's been quite a journey to get to this point and have a service that's up and running and live, I hope it's at the same time a very exciting moment that we get to discuss new treatments that are improving outcomes, new ways of delivering services, and a pathway that we can all play our role within. So I hope it's an enjoyable webinar. We've got an hour, and I've left some time for discussion. As always, talks can get a little bit stretched. I'm sure that hour will go quickly, but if the speakers could try and keep roughly to the times allocated to allow that time for discussion. So first up, Dr. Yvonne Summers, one of our most senior medical oncologists in GM, is going to provide us with an update on this changing area of lung cancer care, multimodality treatment. So thanks very much, Yvonne, for joining us.
Thanks, Matt, and it's great to have this opportunity to spend some time talking about systemic therapy in early stage non-small cell lung cancer today. I'm going to try very hard to stick to time, Matt, but there's a lot to talk about. And I'm going to make no apologies for the fact that the next 15 minutes or so is going to be quite data heavy. The reason for that, of course, is that you need to understand the data to understand why it is we're making different choices for different groups of patients. So stick with me and we'll try and get through it as quickly as possible. Those are my disclosures. So none of the people around this virtual room today need to be reminded that unfortunately our outcomes for non-small cell lung cancer remain very poor, and they remain poor because so many of our patients present with late stage disease. But even for those that present early enough for us to be able to consider a surgical option, the outcomes are still very poor even with surgery. The data on the right-hand side is from years ago before we were routinely doing a lot of adjuvant therapy. But nonetheless, even in this day and age, the real life situation is that about half of our patients, unfortunately, will recur and die from metastatic disease. So there's a very clear need for us to improve our systemic therapies to try and prevent that metastatic disease and recurrence. So we moved from surgery alone with the result of a number of studies that were carried out about 20 years ago now, looking at platinum doublet chemotherapy. And a number of studies were brought together that looked at platinum doublet adjuvant chemotherapy 3 or 4 cycles after surgery. And essentially, this meta-analysis demonstrated that overall, with those studies all brought together, there was about a 5% benefit in terms of overall survival with platinum doublet chemotherapy following surgery. And that benefit was higher in stage 3 compared to stage 2 and stage 1, respectively. But of course, that was really not much of an improvement on surgery alone. And so there's been a lot of trials that have been done that have brought the advances that we've seen in non-small cell lung cancer in patients in the advanced setting through to the surgical arena. And I'm going to touch on predominantly ADAURA, IMPER, and CheckMate 816, because those are the studies that have resulted in changes in clinical practices and drugs that are available to us. And I just wanted to touch on the different types of therapy associated with patients in the surgical setting. So adjuvant means treatment after surgery, post-operative treatment. Neoadjuvant treatment means treatment in that window prior to surgery. And now there's a whole host of studies coming through that we're now beginning to term perioperative, and that involves a neoadjuvant component and an adjuvant component. Those studies have not yet had regulatory approval, but they will do in the not too distant future. So sticking initially with EGFR mutated disease, so patients that have an EGFR molecular driver, the ADORA study looked at patients who had resected non-small cell lung cancer stage 1B to 3. Those patients could either have chemotherapy or not, and following their chemotherapy, if they were going to have it, were randomized to either receive osimertinib for 3 years or placebo. And this was patients with one of the common EGFR mutations, so L858R or exon 19. When this was finally reported, the median follow-up was 5 years, and all patients at that point had completed their 3 years of adjuvant osimertinib. The initial data that was presented on recurrence or disease-free survival, you can see on the left-hand side. So you can see that incredible curve with those massive distance between the patients receiving osimertinib and those who got placebo. The hazard ratio when that was initially reported was 0.2. That means that there was an 80% reduction in the risk of recurrence for patients with EGFR mutated disease who received osimertinib. And when that data was updated with further follow-up in January of this year, you can see that those curves remain split. All of the patients had finished their 3 years of osimertinib by that point, and that improvement in patients remaining free of disease was persistent with a hazard ratio of 0.27. Then later on this year at ASCO, we saw the final analysis with the overall survival. And at this point, you can see that those curves remain split, not so widely split, of course, as the disease-free survival. But when you cast your mind back to that earlier slide that I showed of the benefit of platinum doublet chemotherapy and the 5% benefit, you can see there's a 10% benefit overall for patients with EGFR mutated disease receiving osimertinib on top of any benefit that they had with chemotherapy. And that's about 50% reduction in the risk of death. So really impressive changes that's translated into an overall survival benefit, which has changed our practice. And as we've seen with chemotherapy, the benefit is higher in those with higher stage disease. So you can see the curves are split on the bottom right-hand side for those with stage 3 disease, more than those with stage 1B disease. But actually, even those with stage 1B disease have an improvement with a 6% improvement in overall survival at 5 years. So really across the stages and even stage 1 disease. And what about chemotherapy? So some of the patients in the study had chemotherapy, others didn't. The benefit was persistent whether or not there was chemotherapy. And of course, this means that we have an option for our patients. So not all of our patients are suitable for adjuvant chemotherapy. Many of them will have comorbidities, are frail, or just not fit after surgery to receive platinum doublet chemotherapy. And for those patients that aren't, we can still go ahead and give them adjuvant osimertinib if they have an EGFR sensitizing mutation. So OSI is now standard of care for patients with completely resected stage 1B to 3 disease. With 3 years of treatment, it's really important to remember that this study was the old version of TNM, so it was TNM7. So patients with stage 1B disease on that system with the smaller tumours, so those with 3 to 4 centimetre tumours, can still have access to osimertinib. That's important because those patients are not routinely referred through to oncology for adjuvant chemotherapy. So we need to be on the lookout for those, and underlines the importance of us needing to understand the molecular characteristics of patients in the surgical setting. So that was a bit of a challenge to us, but of course things are now improving in terms of our understanding of the molecular characteristics of patients, because other therapies such as the neoadjuvant treatments are meaning that we need to know those molecular results for all of our patients. And although we're starting, as we're going to be talking about throughout the course of the next hour, about how the one-stop and the pathway is working for neoadjuvant, I'm really optimistic that within the course of the next year to 18 months, we will have molecular testing for all of our surgical patients. It's also really important to review this data because it's important to understand that immunotherapy is not appropriate for this group of patients. So if you have an EGFR mutation, those patients do not benefit from immunotherapy like many of the other molecular drivers, which is why that they're taken out of that neoadjuvant chemoimmunotherapy pathway. There are other oncogenic drivers that have studies ongoing at the moment. And I'll just say a very brief word about the ALINA study, which was a study that we had running at Wythenshawe, which was for patients who had an ALK fusion present. Patients had surgery and were then randomized to either receive alectinib or chemotherapy for 2 years. And you can see the first reports of this below from ESMO just a couple of months ago, demonstrating almost exactly the same disease-free survival curves that we initially saw with ADAURA. So we are expecting alectinib to get approval in ALK-positive disease in the near future, and that will then be the treatment of choice adjuvantly for that group of patients. Moving on from targeted agents to immunotherapy, but sticking with the adjuvant setting, so the post-operative setting, IMPER-10 was the study that allowed us to treat patients with adjuvant atezolizumab post-operatively, because that study took patients with completely resected disease. They had to have chemotherapy and were then randomized to either receive atezolizumab or supportive care. And the study was positive in the PD-L1 population overall, and atezolizumab has a license in that area. But in England, we have access in the PD-L1 high group of patients, and that is because the benefit was most significant in that group, with the overall hazard ratio for overall survival being 0.37. So a very substantial improvement in overall survival for patients with PD-L1 high with completely resected non-small cell lung cancer. So that was approved in March of 2022. It has been tricky. It's been tricky because it's a very select group of patients. They have to have an R0 margin. They have to have PD-L1 50% or more. They have to have been suitable for adjuvant chemotherapy, and about half of our patients don't get to adjuvant chemotherapy for a variety of reasons post-operatively. And we have to have the results of that molecular testing available for us to be able to discuss it. So we've probably only treated about half of the potential patients so far because of some of those challenges. And of course, now that we have neoadjuvant chemoimmunotherapy, the role for adjuvant immunotherapy is less clear. And I would also advocate that for neoadjuvant treatment, we're much more likely to be able to treat more of the potential population of patients. And so that's another real advantage. So moving from the adjuvant setting to the neoadjuvant setting, which of course is what we're all really interested in today, I'm going to discuss initially Checkmate 816, which was the study that has really changed our practice and is why we're all sitting around this virtual room today. So Checkmate 816 was a study for patients with stage 1 to 3 non-small cell lung cancer with TNM version 7. They had to be resectable at outset, and they were randomized to either receive 3 cycles of chemotherapy or 3 cycles of chemotherapy plus immunotherapy prior to surgery. There was no routine adjuvant post-operative component to this study. So you can see the surgical summary from the study. So patients had their neoadjuvant treatment. You can see that the majority of patients were actually stage 3, which is consistent with most of the neoadjuvant perioperative studies. And what's really important and is often a concern to us with neoadjuvant treatments is well, how many patients don't get to surgery as a consequence of having a neoadjuvant treatment. And you can see if you look at on the left-hand side, the patients receiving the chemo IO, 12 and 17% of the stage 1 to 2 and stage 3 respectively didn't get to surgery for a variety of reasons. What is important is those that have disease progression. So consistently across the neoadjuvant and the perioperative studies, the rates of patients that don't get to surgery because of disease progression is about 6%. And for those patients, I would argue, those are the bad biology patients who probably were not going to do very well with surgery anyway, and were probably going to have recurred quite quickly after surgery and perhaps not even get to an adjuvant therapy. And if they were going to get to an adjuvant therapy, it wasn't going to work very well. So I'm less concerned about those. There are also some patients that don't get to surgery because actually they weren't fit for surgery in the first place, or actually they were deemed that they weren't operable in the first place. But I think it's important that we need to be able to discuss with patients that there is a chance that they won't get to surgery. The other thing that's important is patients that don't get to surgery, their outcomes were better if they had chemoimmunotherapy compared to chemotherapy alone. You'll note that the surgery times weren't significantly different between the different stages, and if anything, the surgery times looked a little better for those receiving chemo-IO compared to those receiving chemotherapy alone. So getting to the important outcome data, the event-free survival curves for chemo-IO versus chemotherapy in the neoadjuvant setting, you can see those curves are well split, hazard ratio of 0.63, so again, a nearly 40% reduction in the risk of recurrence, with the median event-free survival being about 20 months in the chemotherapy arm, 31 months in the chemo-IO arm. And what's important is that we have the tumour out, we can look at it under the microscope and see what impact that treatment has had. And about 20% of patients in this study had a pathological complete response, so no tumour viable at all in the surgical sample when it was examined. And that figure of about 20 to 25% is consistent across all of the neoadjuvant studies. Patients who have a pathological complete response, it's much more common with chemo-IO compared to chemotherapy, as you can see from the numbers on the slide. Those patients have a very good outcome. The patients who don't have a pathological complete response, and that can be anything below that from no response at all to a major pathological response, which is 10% or less tumour cells viable. The outcomes for those patients are less good, but there's still a benefit for the chemotherapy and immunotherapy. And that, for me, is the area where we're going to need to do a lot of research to work out what is the appropriate adjuvant post-operative treatment for those patients. What about overall survival? That's the thing that drives us. So this data is not fully mature yet. It's a 3-year update, but you can see those curves are remaining split with a nice flattening out. The hazard ratio is 0.62. So again, that same disease-free survival benefit we're seeing coming through into overall survival. So almost a 40% reduction in the risk of death because of chemotherapy, immunotherapy compared to chemotherapy alone. That wasn't statistically significant yet, but we expect with more follow-up it will become significant. So a really major advance in treatment of our patients. It wouldn't be right for me to finish without mentioning perioperative treatment. So that is adjuvant treatment plus neoadjuvant treatment. So there's about 4 or 5 studies that have reported this year, none of which have regulatory approval, but it's all coming through with different sorts of immunotherapy agents, which are all very much the same. The study design is all very similar in all of the studies. So this is taking, again, patients with resectable disease, treating with 4 cycles of chemotherapy in this case, or chemotherapy with pembrolizumab, surgery, and then a year of pembrolizumab for patients receiving chemo-IO neoadjuvantly. And we've got overall survival data from this study that was presented at ESMO just a few weeks ago. And you can see that the overall survival curves on the left-hand side are well split. It's statistically significant, the difference, with a hazard ratio of 0.72, so a nearly 30% reduction in the risk of death with perioperative chemotherapy, immunotherapy, with pembrolizumab compared to chemotherapy alone. And the other thing I would point out is look at those survival curves. So this is again was a study of patients predominantly with stage 3 disease, and you can see 4 years, 2/3 of patients being alive, which is quite remarkable when we think about what our traditional outcomes for patients with stage 3 disease with a surgical approach are. So really substantial improvements for the outcomes for our patients, and the event-free survival curve very similar to those that we've seen previously. And in terms of pathological response, again, 20% of patients receiving pathological response, less than 5% for chemotherapy alone. But we do have some questions about perioperative studies. Certainly I have some questions. Yes, the hazard ratio is 0.72. That's very similar to the hazard ratios we've seen for the neoadjuvant studies. And I know you're not supposed to do cross-trial comparisons, but of course that is what we do. We need to work out how this data fits in with our neoadjuvant strategy. There are additional costs, and I don't just mean financial costs, I mean cost to the patient. It's a year of treatment coming up to the hospital. It's a year of potential toxicity. And although the discontinuation rates are low, you can see from that table 5.8% for patients receiving pembrolizumab, there is obviously still toxicity that is leading to discontinuation in some patients. And we also as yet don't understand some of the long-term implications of immunotherapy. So it'll be interesting to see. This will undoubtedly get regulatory approval with the FDA and the EMA, but whether it gets through NICE or not with some of the health economic analysis that has to be done, I think is much more doubtful. So that's what we have. So in the UK, we have neoadjuvant chemo IO as per Checkmate 816. We have IMPER 010 in PDL1 high, and we have a whole raft of studies that haven't got regulatory approval yet of chemotherapy, immunotherapy neoadjuvantly with an adjuvant immunotherapy component. And we have to think about how this all fits together. It's helpful for me to put it into the context of, well, what are we doing with a neoadjuvant treatment that's different to an adjuvant treatment? And of course, for a neoadjuvant treatment, we can treat more patients because more of them are fit for treatment preoperatively. There's also the situation where the tumour is still in situ, and so the immunotherapy has tumour antigens present, and therefore, hypothetically, an advantage in terms of being able to be effective. And we've also got some data thinking about preclinical setting from animal models. So you can see on the top, this was an animal experiment where mice with tumours were given either neoadjuvant or adjuvant immunotherapy. And the outcome from that is that there's basically less disease burden with neoadjuvant treatment rather than adjuvant treatment when those mice are sacrificed and the tumours examined. But much more important than the animal models is what happens in real life in human beings in other disease settings. And one of the most important studies, I think, was presented at ESMO last year in melanoma. And this took melanoma patients with the same immunotherapy, but either all given post-operatively as adjuvant therapy or 3 cycles of pembro neoadjuvantly and the rest adjuvantly. And you can see from that survival curve a substantial benefit with the neoadjuvant component. So for me, this is really important and gives us some important validation of some of those hypotheses about why neoadjuvant therapy is so important. There's some other questions around all the neoadjuvant studies. We've seen consistently that the benefit is highest in stage 3 compared to stage 2, is higher in high PDL1 rather than low PDL1. But Marina Garasino at ESMO did a very nice meta-analysis of all of the perioperative studies that have been presented this year. And you can see if you focus, for example, on the right-hand side at that stage 2 curve, the forest plot for all of those studies brought together is very firmly to the left of the midline. So even for stage 2 patients, there's a clear advantage with chemoimmunotherapy, and the same even for those with PDL1 negative that you can see on that bottom forest plot. So what does this all mean? Well, new treatments are absolutely improving the outcomes for our patients. And the benefit from our targeted therapies and immunotherapy is much better and much greater than the benefit that we've historically seen with chemotherapy. Post-operative adjuvant therapies are now available for particular subgroups, such as those with EGFR mutations and coming, for example, for those that have ALK fusion. Neoadjuvant chemotherapy is currently available for patients with with potentially resectable stage 2 and stage 3 disease. Patients must not have EGFR or ALK because of the better therapies that are available for those and the fact that they don't benefit from immunotherapy. But for all PDL1 groups, and remember that's different to the adjuvant setting where it's only for PDL1 high. Communication with the patients from the outset is key. So it's not just about surgery anymore, it's about that entire package of care with systemic therapy that's going to form part of their treatment so that they're prepared for it and much more open to hearing that actually there might be a treatment before their surgery, but it's all part of the package of care for them. We need to know the molecular profile at diagnosis for a whole variety of reasons, but most importantly, immunotherapy is not a good option for patients with molecular drivers and for never smokers. And this is all meaning that we have to have very major pathway change across England, in fact, the whole world. And through Manchester, we're going to deliver that through the One Stop, and we have been beginning to deliver that through the One Stop, and we're going to hear much more discussion about that as the webinar continues. My personal perspective in all this is that for all stage 2, 3 patients with resectable non-small cell lung cancer who don't have an oncogenic driver should be considered for neoadjuvant chemoimmunotherapy. And with that, I shall say thank you and hand over.
Fantastic. Thanks, Yvonne. A really, really clear presentation of a complex area. So many thanks for taking us through all of that. I'm going to run through the presentations and then try and collect all the Q&As towards the end. So please do use the chat function to put your questions in as they come up. If you're thinking it, probably somebody else is thinking it. So please do put it in and we'll try and get through as many as we can. So next we're going to move on to Felice Granato, our lead surgeon at Wythenshawe, who's going to talk about what the impacts are from a surgical perspective of this.
Let's start over again. So a few considerations with regard to complexity of surgery after neoadjuvant treatment, in terms of a few considerations in terms of outcomes after neoadjuvant treatment, and a few words with regard to how we're going to assess from a surgical perspective resectability for patients with non-small cell lung cancer, in particular those ones undergoing chemoimmunotherapy prior to surgery, and then we'll draw some conclusions. So the operation after neoadjuvant treatment is more complex for a large variety of reasons. Some of them I will be able to show you based on evidence. Certainly, the lymph node reaction following immunotherapy, it is to a certain extent difficult to manage intraoperatively for the complexity in relation to desmoplastic reaction following immunotherapy, but also as an assessment of possible wrong interpretation of progression or pseudo progression. In a nutshell, surgery is more difficult, complex, and lengthy. Minimally invasive surgery, in particular VATS, is less feasible, and there is good evidence in the literature that the rate of conversion from VATS to open is very high in the neoadjuvant chemo IO setting. We do have concerns in terms of drop rates after chemoimmunotherapy, in terms of delay to surgical resection, in terms of disease progression, and in terms of failure to achieve CPR, MPR in relation to PD-L1 status. And we have some concerns, less so in terms of possible incomplete resection. Some minor concerns in relation to impaired healing. For what concerns the factors that increase surgical complexity, I think these slides illustrate the issue relatively well. It's published on JTCVS, and it talks about how immunotherapy at level of previously involved lymph nodes, particularly N1 location, which affect hilar and subhilar dissection, and therefore affect the complexity of the operation more of N2 or mediastinal nodes. The effect of immunotherapy on those lymph nodes induces a inflammatory desmoplastic fibrotic response that makes the lymph node very, very stuck to the pulmonary artery, so much so that in presence of N1 disease, guidelines are now advising to have central control of the pulmonary artery and to approach vascular resection with alternative options such as a sleeve. In a nutshell, we need experienced surgeon to do this operation. We need experienced anesthetist and experienced team in theater to do this operation. We need to inform patients adequately about possible risks and possible outcomes, and we need to have some blood in the bank before we start. And this is a good skill that was proposed on the basis of the NeoStar trial with regard to the complexity of the operation identified before and during the operation with regard to lymphadenopathy, fibrosis of peripheral fibrosis, adhesions, and central versus peripheral lung cancer, finding out that assuming that a score of 2 is what characterizes a normal resection of a patient undergoing stage 1 lung cancer surgery without neoadjuvant treatment, the more than 40% of patients in the NeoStar study, more than 40% of the patients who had surgery after neoadjuvant were found out to have a score higher than 3. Moving on the assessment for resectability for lung cancer, in relation to the complexity of what we have described, and to a certain extent, I think is sometimes not recognized at MDT level, on how more difficult the operation becomes after neoadjuvant treatment, we felt as a team within show that we wanted to make sure that we defined resectability for non-small cell lung cancer in a fashion that is obviously collegiate and multidisciplinary as possible, but ultimately relies on the people who are actually going to be doing the operation after neoadjuvant treatment. And these people, just as a quick reminder, these people are the surgeons. So we defined resectable lung cancer, anything that can be removed without zero margins, can be removed without removing organs that are needed to survive, and the tumor that can be removed with a cumulative risk of R1 and R2 not higher than 20%. With regard to N2 disease, we defined resectable those patients who have non-bulky lymph node disease, so lymph node short axis, smaller, shorter than 25 millimeter on a CT preoperatively. We consider resectable even tumor that can be removed with a pneumonectomy. I'm not sure whether I've seen this in Yvonne's slides, sorry, but pneumonectomy survival rate after neoadjuvant treatment for stage 3 and over is significantly improved. So we wouldn't advocate not to perform pneumonectomy even in presence of N2 disease, as long as the patient can tolerate it, of course. We define non-resectable, on the contrary, every cancer and patient that has a cumulative risk of R1 or R2 higher than 20%, that can be resected only with removal of vital structures. And for patients who have N2 disease, we define non-resectable, obviously those lymph nodes which size is bigger than 25 millimeters, and that can be removed with a pneumonectomy, but the patient is not able to tolerate it. So on the basis of that, we have agreed that to define resectability to help defining resectability for patients with non-small cell lung cancer, we will introduce a meeting called Friday Surgical Friends, where a number of 3 or more thoracic consultant surgeons will review patients referred for surgery after neoadjuvant chemotherapy, pretty much establishing whether they are resectable or not, therefore supporting or of changing a status that was previously assessed at MDT level, and obviously better defining in a sort of collegiate fashion the extent of the operation and the required to perform resection. We will also aim to review patients who have been reviewed to do one-stop clinic setting. We will make sure that a thoracic surgical presence is mandatory available at one-stop clinic, and we will prioritize those patients who have completed neoadjuvant treatment and we have deemed resectable to receive surgery within 2 or 4 weeks maximum from completion of oncological treatment. Clearly, we feel that this is in patients' best interest, as allows standardization of the term resectable, which more and more is challenged by all colleagues within the context of MDTs, as it is crucial, as we know, for enrolling patients for neoadjuvant chemo IO. We feel that this will allow a higher proportion of patients to access neoadjuvant treatment on the basis of a supportive approach from the surgical team, will minimize inequality, will increase the non-cancer resection rate and hopefully will minimize waiting times and risk of progression throughout treatment that we know it is a significant issue. And clearly, it makes work within thoracic surgery as collegiate and standardized as possible. And I want to finish this presentation giving you a bit of an overview on what I think will be the way in Manchester for sure, as we mature with robotic thoracic surgical program to perform surgery after neoadjuvant treatment, and that will certainly be robotic surgery. We can see from this real prospective cohort study of patients undergoing neoadjuvant chemoimmunotherapy for stage 3 lung cancer that surgery performed with a robot in 44 cases in obviously experienced hands has led to all R0 resection, minimum conversion to open, and very favorable results in terms of every other complication associated with surgery. This study, which is a Chinese study, clearly supports the role of minimally invasive surgery as robotic surgery to assess surgical management of patients after neoadjuvant treatment, as we have significant evidence that I'm not able to present due to time shortage from the literature that performing BATs after neoadjuvant treatment leads to a rate of conversion of around 40 to 50%. And although probably not quite there yet, but I think we are really getting there in terms of our experience in robotic surgery to be able to do this very, very soon. You can see from this slide, sorry for a little bit of confusion, that we have now performed over this up to December almost 100 cases on the robot, large majority lobectomy and segmentectomy for lung cancer. And the outcomes have been very, very good. So we feel that the challenges of taking on robotic cases in terms of post-neoadjuvant treatment is almost ready to go. In conclusion, I think that we shouldn't underestimate the complexity, surgical complexity of performing an operation after chemo IO, and we shouldn't, and we should certainly consider that when we discuss outcomes, and sorry, when we discuss feasibility for management in one-stop clinic, together with the other factors such as PD-L1 expression, such as fitness, so on and so forth. We know though that if this is done from good evidence in the literature, if surgery is done in expert hands with collegiate agreement and support by the rest of the surgical colleagues, results are good. And we recommend that that is replicated in Manchester, and we would like to do that with these surgical friends. We feel that accurate planning of surgery is certainly preferable, and we feel that a support of a second opinion at hand from a surgical perspective at time the operation is recommendable. And as I alluded before, maturation of our robotic program will certainly in time allow us to adopt this technique to continue to perform minimally invasive surgery for patients with local advanced lung cancer after chemoimmunotherapy. I hope, Matt, despite technical challenges, I have been in time, and thank you very much.
No, thanks for bearing with us as this sound disappeared before. And just to reassure everyone, we're not kicked out of here at an hour. So if we do run a few minutes over, that's okay. We'll give everyone the opportunity to speak and try and get through questions. So thank you, Felice. It's what a time for thoracic surgery, introducing robotic surgery and this new treatment paradigm of neoadjuvant stuff. So what I'm going to do now is just broaden it out a little bit and think about our GM pathways, and particularly, I guess, a focus on what happens before they come in to the one-stop. A little bit about the one-stop, but what we all need to be doing. I think Yvonne laid out really clearly how important it is that we get this pathway right from early on to try and deliver the optimal experience, make sure we're not creating delays, and reap those benefits that we've been shown. And I think there's a few areas where that sticks out in the pathway. So as anybody that delivers a diagnostic service, whether that's an image-guided biopsy service, whether that's a bronchoscopic and EBUS service, we've got to now really have a laser sharp focus on the quality of the staging procedures we're doing, and then the quality of communication with our pathology teams, with our MDTs, and across the region. So in the diagnostic and staging setting, the importance of staging EBUS, which was already exceptionally high for accurate staging, is even more important now, and we do need a meticulous focus on staging EBUS. So it's just really that reminder. So one of the nice indications is any N1, N2 lymph node metastasis. So if we identify preoperatively that someone has a lymph node metastasis, it may well open the door to a different treatment paradigm now that wasn't there before. It may change those pathways. So it becomes critical that we do that. And it's just a reminder that the nice guidance is any patient that has a thoracic lymph node that measures over a centimeter, 10 millimeters on the staging CT, they have an indication for a staging EBUS, regardless of PET findings. If they've got normal sized lymph nodes but FDG avidity, they obviously go on to have a staging EBUS as well. But anybody with a lymph node greater than 10 millimeters requires a staging EBUS, and that has to be systematic in both its examination and its sampling. And the other we've had this mindset, I think, slightly before, where when we do a diagnostic EBUS in the more advanced stages, we're trying to get as much tissue as possible for all the molecular markers. And in a staging procedure, we're mapping out the extent of disease by sampling lots of areas. But now those two things come together, because we've got to have the thought process and thinking, this person looks like they might go down a neoadjuvant route. And so I'm consciously trying to make sure we get adequate tissue so that the EGFR, the PDL1 is successfully done, and it helps inform the management. The other thing is then the pathology and the genomics pathway, and we spent a long time trying to figure out the best way of doing this. And so what I'm going to talk about now is specifically the neoadjuvant pathway. So it's when we're seeing somebody, I might be doing an EBUS and think this person has what looks to be very resectable disease, and this person looks fit. It looks like they could well be a neoadjuvant person. And just having that mindset that, well, now I need to communicate that with the pathology team so that they know that. And it's all laid out in the latest reflex testing protocol for GM. As with all the communications that have gone out recently, the full reflex testing, so every single stage, every single sample, is to come in the future. But this specific neoadjuvant pathway is what we're using now. This is the process we use to ensure rapid molecular marker testing to facilitate this pathway. And the two things that we need to tell a pathologist is, one, that this is the clinical diagnosis is lung cancer. And that means that they know it's quite a focused immunohistochemistry before moving on to the molecular marker testing. And they need to know we are considering this person for the neoadjuvant pathway, because it changes what they do. So if we tell them and say, this is a person being worked up for neoadjuvant treatment, and in that specimen is non-small cell lung cancer, they'll know there's an urgency of PDL1 and ALK via immunohistochemistry, and that's what we can use for clinical decision making. But also that they will send that sample to the GLH and tell the GLH that this patient's on the urgent neoadjuvant pathway. And it is laid out in that document. This is the form that pathologists fill in as they send a sample to the GLH, and they will write the same phrase, urgent neoadjuvant pathway, and select the clinically urgent EGFR test. So that's the COBAS single gene test, and that has a quicker turnaround than NGS. Full sample will still be sent for NGS, but the quicker EGFR sample will be activated, and we will get that sample back quicker. I've just put in the reminder that COBAS picks out the common EGFR mutations, but it can miss some. And so for your MDTs, when you're discussing patients, the tobacco history becomes very, very important, because in somebody who is a lifelong non-smoker, it might influence what you do to say, that the COBAS test may not be enough to fully understand an EGFR status, or it might be across your surgical and oncology team, the decision is for upfront surgery because of that, the very high likelihood of a mutational driver. And that's all the discussion to be having in your MDT as you're planning your management. So that's at the doing the procedure in the moment of procedure, having that real focus of identifying someone that could be for neoadjuvant and getting that information into the clinical information text. This is just an example from an EBUS I did recently. It's probably got too much, it's really laboring the point. But right now, as we're embedding new pathways and getting to grips to us, that probably isn't a bad thing. And telling the pathologist this is a case of lung cancer, clinical diagnosis of lung cancer, that they may well be suitable for neoadjuvant. So it's the urgent immunohistochemistry and the clinically urgent EGFR test as per protocol. As we linked into this is the single queue program, and where there are diagnostic procedures being done in different areas of the region. It's really highlighting just how important the communication between the physician team or diagnostic team and the pathology team are, about making sure they know who to contact if there are queries about the samples. So all of this is just highlighting just how important the communication is across our diagnostic teams. Because if we get this right early on, it pays the dividend later on as we can make fast and quick decisions. So at the MDT point, that's another kind of safety net or point in the pathway, because you may discuss someone with resectable stage 2-3 disease, and your surgeon that's present, medical oncologist is present, and everyone is in agreement that this seems like a suitable case for the neoadjuvant pathway. Do discuss with your pathologist then and there. Where is the ALK up to? Where is the PDL1 up to? You may have it already. Has the urgent EGFR testing been done? Because you're going to refer that person to the one-stop via the surgical referral process. It's a surgical referral. But as I'm going to show, the amount of detail you can give us becomes really critical in how that referral is managed. So if the person triaging that referral, and there's a consultant-led triage every day, knows when the tests have been requested, what's been requested, it helps them understand when that person's coming into the one-stop. And this is, I guess, don't want to get too bogged down in the internal workings of our processes. This is it is a new thing within MFT and within the surgical triage and referral process, and we've got to standardize things. As with anything that's new, there's been some bits of confusion about what exactly happens with these referrals. So I think there's just an important couple of things to say, and that's that it is not the case that referrals will only be accepted once those molecular tests are back. It's not the case, wouldn't be appropriate. The referrals are accepted, and the ideal situation would be that a patient comes to one stop and they've got those results there. You've got a PDL1 there. You know if they've got adjuvant options, you can have a full discussion with them. But that may not be possible, and each case needs to be reviewed individually to look at the case, look at the disease pattern, the disease burden, when those tests have been done, and it is absolutely appropriate for patients to come to the one-stop without those molecular tests. That might be something you discuss in your MDT. The more information you give in the referral to guide that triage process, the better. So it's ideally we try and get patients in with those results, but it's entirely appropriate to see people without them. There might be a clinical urgency for that. There might be a pathway reason for that the tests have only just gone. And if we know that, we know that they need to get in straight away. And then they'll be seen in the one-stop, and it's the expanded indications for the one-stop now, because now we've got the addition of a medical oncologist in that clinic, and we can discuss multimodality treatments. So this SOP has gone out across the region, and it just describes what the indications are, what the indications aren't, because people where they've been decided for best supportive care, where it's been decided it's for radiotherapy alone, where it's clear it's not resectable disease and it's non-surgical multimodality treatment. Those patients don't need to come to the one-stop. There might be individualized factors in a case that means someone requires upfront surgery. That might be a lifelong non-smoker. They don't need to come to the one-stop because you and your MDT with your surgeon and oncologist have made that decision. So the one-stop is for resectable stage 2-3, where either your MDT has said this person's for neoadjuvant and you're referring them to us, or equally, if you feel like there's a benefit of them meeting different specialties, there might be equipoise between different treatment options, and you feel it's a good place for them to come. Good. So a bit of a whistle-stop tour through the different parts of the pathway and all of our responsibilities about how we deliver that process. We're going to finish up now just with hearing the voice of the nursing staff, really, that are right at the heart of the one stop that we've now been running for virtually a year and a half, just to tell us on the reflections of the processes of patients coming in to meet multiple different specialties and make decisions on the day. So I'm going to hand over to Siobhan, Kath and Karen, who are going to take us through their thoughts.
Thanks, Matt. So Karen and I have been asked to speak about keeping the patient at the centre of everything that we do. As Matt said, it's been about a year and a half now that the One Stop Clinic has been running, and we've seen almost 400 patients. It's been a great experience to be part of the One Stop Clinic. The primary goal of One Stop is to support the patients through what is an incredibly complex appointment. It was designed to reduce waiting times in between all of the treatment pathway, and that's what it's done, but that doesn't make it any easier for the patient. So keeping them at the centre of what we do is always our primary goal. Individualised patient care means that we need to ask about them, we need to ask about what they're worried about and what is most important for them, for us to take into consideration when we are making decisions about what is going to be life-changing for them.
I suppose what we've learned is that the flow of the clinic absolutely ensures that the patient and the family voice is heard, that their opinion, that their concerns, we listen to those early on, right at the beginning, before anyone else has even spoken to the patients. They get supported by one of the nurses who asks their opinion, asks what's happening for them. And that then is discussed and is upfront and in the forefront of people's minds during the MDT. But they're then supported throughout all the consultations by the same experienced nurse who is supporting the patient, but also listening to the conversations and the information that's being discussed. And I suppose a little bit of ensuring that it's what we discussed in the MDT, but also a little bit of explaining and observing the patient and the family reaction to that information. When we need to stop, when we need to slow it down, when they need some more explanation. So despite the complexity, despite how complicated all the information is, that they are centre of and well and truly within those conversations. And going forward, as Dr. Summers and Mr. Granato have discussed, this is going to become more complex. So actually ensuring that they're supported throughout it is going to be even more important. These patients and families have an opportunity to stop in between consultations and discuss with any one of us, but with the lung CNSs throughout the morning to just take a minute, make sense, and then go on to the next person. And it's a really important part of the whole process, I think, and something that we've learned that's even more important to them.
Recently, we've had a look at some data as the amount of patients we've seen has grown. Everybody's very interested in outcomes and how we've performed, which is absolutely right. We recently looked, and about 86% of our patients have made a decision on the day as to what treatment they're going to have. It doesn't mean to say it's absolute or it's right for everybody, because we equally want to hold people if they don't make a decision on the day and support them to have time with their families or loved ones to process everything they've been told throughout the appointment and make a decision a few days later. But 86% is pretty good, isn't it? Another thing that we're measured on is do we successfully screen people for things that will optimize their health for whatever treatment they have. So tobacco dependency, frailty, alcohol dependency, and prehab. And we are incredibly lucky to have representatives that can actively manage those things in the short window between the appointment that they have at the one stop and the start of their treatment. We get 100% of our patients screened for those things, and that's massively important to us.
And I suppose with that, with those assessing them for those other aspects, it highlights the holistic approach of the one stop, which means that these patients are prepared and ready for any of the treatments. And again, as it becomes more complex or their treatment plan becomes longer, that actually they're part of that, and we're supporting them with the other aspects that will get them through treatment. I suppose these are the things we've picked up and we've learned. From a difficult point of view, there is lots and lots of information, and we know that that's going to get more and more. But the process, the movement through the clinic, the having somebody with them all the time, we know mitigates that and makes that better for patients and families. We know it's very anxiety provoking, this clinic. So actually environment, arriving, being welcomed, having a phone call the day before to explain what's going to happen just supports people, so that although anxiety is there, actually they're in a position to listen and to hear the information. We struggle a little bit with patients that come with a firm view of what treatment they want or what they think is best, and we're going to have an added extra in the mix with neoadjuvant. But that again is about hearing what the patient's saying, discussing that within the MDT setting, and then supporting the patients with any differences to their held opinion. We know it's a long morning, so time, space, environment, tea and biscuits are the things that really, really make a difference. Just that little bit of care around all the complexity helps and makes a difference. We also know that one of the hugest benefits is absolute shared decision making. Patients and families are absolutely involved in the decisions they're making in terms of their treatments. And sometimes the MDT will come up with one decision and the patient decision is different to that. And that's the right thing for that individual patient. There is absolute true involvement in that decision making. It's really beneficial to hear all the information in one sitting, although we know it's a lot of information. To be able to weigh up the pros and cons and the benefits and the risks by hearing it all at one time definitely means that they come to a good decision. And that holistic support, demonstrating that the exercise side of things is really important, that we value that supporting them with their smoking is an incredibly integral part of what we do, is important as well. So pulling the neoadjuvant patients within to that clinic and still then being able to access all of that will make a significant difference. And that's it from us.
I just wanted to add the addition of support following the appointment has also been something that we've expanded. Engagement calls to make sure people are actually in touch with prehab and smoking cessation, and with neoadjuvant that will only increase, keeping a constant support and a port of call for people to signpost in the right direction. So we're very excited about neoadjuvant coming on board, aren't we? Thank you. Thank you.
Real thanks. Thanks, Siobhan and Karen. A great reflection of just why the patient-centered approach that happens in One Stop, that I think everything we've talked about today shows just how important that's going to be. There's a few questions. I know we're a bit over time, but I think there are some important things just to cover. At first, I guess, is a question for everyone, and maybe I'll ask Yvonne first. That we could be seeing people in a post MDT clinic and starting to talk about neoadjuvant and introducing that idea. And you talked about how important it is that the communication begins at that early stage. And if a patient says back to us, "I just want to have this out. I just want," and there is that thing in their mind about surgery happening quickly. What advice do you have for us about how we approach that conversation and how we try and make that conversation easier when they do come and see you?
Yeah, thanks, Matt. Well, the first thing I would say is actually I've seen a real evolution in communication over the last 15, 20 years anyway. So when we go back to um, when we started doing adjuvant therapy back in 2004, the patients always came not wanting to have any treatment, thinking the cancer was out. That was it. They didn't want to hear about chemotherapy. And we had a real struggle at that point. But actually, what's happened since then is that what, particularly the surgeons have been so good at saying to patients at the outset, actually, you're likely to need to see the oncologist. There's likely to be a package of care. It's likely to be chemotherapy afterwards. And that has made our job in terms of convincing people so much easier because they've heard about it at an earlier stage. But I completely agree with you. Patients do come with set ideas, and that's we're beginning to see that in lung cancer. But our other colleagues in other disease areas have been experiencing that for a long period of time. And I guess what we need to do is always listen. So listen to what the patient has to say, listen to why that is. I mean, I can give you a brilliant example of one of our patients who I think has been operated on this week. I won't say any names, but anyway, she came with not wanting surgery, having a very fixed idea about wanting radiotherapy. And the reason for that was, you need to pull it out of what the reasons behind it is because her partner had prostate cancer, and there's clinical equipoise between radiotherapy and surgery and prostate cancer. And so once we understood why it was she wanted that, she listened much more. And actually, through the course of the neoadjuvant treatment, we didn't expect it to be a positive aspect of neoadjuvant treatment, but we managed to get her to the point where her anxiety was such that it was much more acceptable for her to have an operation because she understood why it was different to prostate cancer. And we managed to, with a lot of work with the CNSs and other patients, get to the point where she was happy to have an operation. So there's a bit about listening, understanding always why it is patient has come with their reason, because there's often things behind it that you can then work on. But I think the other thing is just to implore patients to have an open mind. We understand that they have some preferences and we need to understand what those are, but they also need to have an open mind and listen to why it is we might have a preference one way or the other. But listening to them, so there's no point in us saying, no, you're wrong. That's not what we want. You need to listen, you need to understand why. And when you understand why, you've got a much greater chance of overcoming for whatever the hurdles are.
Brilliant. Karen, any thoughts?
I think the one stop's really helped us with some of this because we've had a little practice at this already, in that we've had patients that come to one stop with a very fixed idea that they either want surgery or they want radiotherapy. Often it's surgery because they don't know what radiotherapy entails or what it is. It's a familiarity thing, and we've worked through that, and people go away with an understanding and make a different decision often that of what treatment's right for them. So I would absolutely agree with you. I think we have a responsibility, either as clinicians, all of us, that patients should be exposed to all their options. We shouldn't just listen to them saying, I want this and that's that, because we have to understand, as Yvonne says, why they're making those decisions, but also understand that we're in a privileged place that we've got this information. Patients and families haven't. So we have to give them the information before they make that decision. If they then make a decision that we're not completely happy with, but we know they've got all the information, that's okay. But we should never let them make a decision about neoadjuvant without seeing an oncologist, I suppose, is my take on it.
Yeah. So very much keep that phraseology around keeping an open mind. You're going to go and meet everyone to get all of the information available and help support, make a decision.
Yeah.
Okay. Yvonne, again, so there was a question about R1 resections after neoadjuvant treatment and radiotherapy. Is that a normal process afterwards? You've discussed that in an MDT setting to see if the question was about adjuvant radiotherapy
Yeah,
for
so
R1 resection.
Thanks, Matt. So I think David had also mentioned in the chat, but it doesn't change our normal referral pathway. So actually, although I said within Checkmate 816 there was no adjuvant therapy, what I meant was there was no routine adjuvant therapy. So anything that needs to be done for clinical reasons still happens. So for example, if there was an R1 or an R2 margin, absolutely patients would be referred to radiotherapy. With R1 for discussion, because of course, we don't always treat all of the R1 patients because there's different reasons that we call things R1 these days. So some of those do need to come back to the MDT for further discussion. Some of them has treatment, some of them don't, but the same processes that we always go through will continue to be followed.
Yeah. There's a question about prehab for cancer, and if the protocol changes, it doesn't. It's just as important, and so we need to be referring people for prehab for cancer. As you know, we're in a lucky position that anybody having any form of treatment for lung cancer in GM can be referred for prehab, and this is no exception. And then I don't know if Felici's turned his camera off, but there is a question about the Friday surgical friends meeting and how it fits in terms of time with the patient's local MDT and the one stop. So he may have had to take a call or something. I think the understanding of that is it's giving the surgical team a forum. So they may have made an opinion about resectability, or even an opinion about the type of operation that would be required. And it's giving them, in this new area of care, a peer support network to say, this is the opinion I've provided. And if there are different opinions or there are additions to that, it's something that then supports the discussion when that patient comes to the one stop. I think the other form for it was post neoadjuvant treatment, again, to have a bit of shared decision making and collective responsibility, because we're going to have to start learning about pseudo progression or nodal flares after neoadjuvant, and the types of operations that are going to be needed afterwards, and that gives them all a forum together to be for that collective responsibility, which I think is how that's going to work, which feels a very good thing to be doing, trying to be as standardized as possible whenever we're implementing something new. Okay, we are a little bit over time, but I thought that was important to give everybody the opportunity. A big thank you for bearing with us when we had a few technical issues and sound issues. But thanks very much to the speakers, and thank you all for coming. And I hope that's been useful. And I look forward to seeing just this develop in the coming months as we treat more and more people on the pathway. So thank you very much, everybody. We'll draw it to a close there.
Thanks, Matt.
Thank you.
Thank you.